So good morning, guys. So today I am going to talk about the surgical conditions of a biliary system. In the last class, we talked about the surgical conditions of the pancreas, like acute pancreatitis, chronic pancreatitis, and carcinoma of head of the pancreas, or carcinoma of other parts of the pancreas as well. And I have already uploaded the YouTube video regarding that. Okay, please have a look at it. Now, for today, let's completely focus on the pathology or surgical conditions of biliary system. Now, let's start with a bit of anatomy here. The biliary system comprises of, see this, the bile duct. Okay, this bile duct, I starts right from the very small canaliculi. These are called biliary canaliculi. These biliary canaliculi will combine with each other and form a bit bigger type of duct. Now, inside the liver, we call them hepatic duct, right hepatic duct and the left hepatic duct. These two hepatic duct fuse together to form common hepatic duct. This common hepatic duct is present at the porta hepatis, isn't it? At the porta hepatis. Now, see this. Gallbladder is there, and this gallbladder has a cystic duct. When the cystic duct joins with common hepatic duct, we call it common bile duct. So the CBD, or common bile duct. Now this common bile duct will, go downwards behind the head of the pancreas. Okay, behind the head of the pancreas and opens into the second part of the duodenum at major duodenal papilla. That place is called major duodenal papilla. There is, okay, a ampulla of Vater present there. That ampulla of Vater is also joined by the pancreatic duct. So both of these open together at the same site. Now, what is the important applied anatomy regarding this fact? Common bile duct, okay, is descending downwards at the back of the head of the pancreas. So any tumor at the head of the pancreas can directly compress the common bile duct. Now, what will happen if common bile duct is compressed? Yes, anyone?
Obstructive jaundice.
Obstructive jaundice.
Exactly, obstructive jaundice. Very good. So we have already done that.
Pancreatitis.
Exactly. Not only obstructive jaundice,
Pancreatitis,
but also
obstructive
pancreatitis.
jaundice.
Very good. So both obstructive jaundice and acute pancreatitis can be caused by, the compression there. Having said that, the acute pancreatitis is not that very common with simple obstruction only, because the obstruction has to occur exactly at that ampulla of Vater region, and that is usually done by a very small stone which is lodging there. Okay, but you can safely give this answer. Obstructive jaundice and acute pancreatitis are the two important complications of obstruction at that site. Now see that? So the bile flow into the second part of the duodenum. Now bile is produced by liver. Bile is concentrated by gallbladder, and when we eat food, okay, when we eat food, there is contraction of the gallbladder. Okay, there is one important hormone known as cholecystokinin, which is released from the intestine. That hormone, okay, causes contraction of the gallbladder. So the concentrated bile will flow into the cystic duct, and it will join the common bile duct, and it reaches the second part of the duodenum. And this bile is very much necessary for the digestion of fat. Without bile, fat digestion and absorption is impossible. This is important point. Okay, so one small correlation again. That's why in obstructive jaundice, okay, there is no fat absorption, leading to fat malabsorption, which is known as steatorrhea. And if it occurs for a long time, then fat soluble vitamins are also not absorbed. So can you tell me what are the fat soluble vitamins? Yes, what are the names?
Vitamin A,
A,
D,
D,
A,
and
D,
K.
E, and
K.
K.
A, D, E,
ADK.
vitamin A, D, E, and K.
Very good. Everybody know that A, D, E, and K. So in a short term, probably nothing will happen. But over a period of time, those vitamins are also not absorbed, leading to multiple vitamin deficiencies. So these are some of the important points regarding the anatomy of biliary system. Now let's move on. The first, surgical condition which I am going to highlight in today's class is cholelithiasis. Okay, cholelithiasis means stone formation in the gallbladder. Lithiasis is stone formation. Chole is the term we use for the gallbladder. Okay, so see there, stones in the gallbladder, and 85% of the stones are composed primarily of cholesterol, while the remaining 15% are pigmented stone. In pathology, you have already studied that. Mostly they are cholesterol stone, and remaining are pigmented stone. Now, why are they pigmented? Which pigment is important for the formation of this stone? Which pigment?
Bile, sir.
Okay, bile,
Bilirubin.
or you can say bilirubin. Okay, you can say bilirubin.
Yes, sir.
That bilirubin is the
Yes.
pigment, and that bilirubin, especially the unconjugated type of bilirubin, is important here. And hemolytic jaundice is the condition where excessive unconjugated bilirubin is produced. So there is a connection between pigmented gallstone and chronic hemolytic anemia. So always remember this relation, because I have to take a good history regarding this. I have to ask certain question. Any other family member affected by the gallstone or not? Who knows? Hereditary spherocytosis may be running in the family. Okay, so questions like that should be thought. Regarding the incidence, okay, approximately 10% of the US population has gallstone. It is written because they have done a good study regarding this. But if I extend this, data all over the world, it almost matches. There are lots of people all over the world who suffer from gallstone, especially the female. Let's move on. Now see there. What are the risk factors now? Risk factors for gallstone formation. The typical ones are female sex, okay, the fat type of female who are obese or overweight, in the reproductive age group, that is called fertile, and the age is 40, okay, or fourth decade of life. These are easy to remember. Fat female who are at the reproductive age group, and they are 40 years of age. Now, other risk factors include Native American race. Okay, again, this study was exclusively done in United States. That's why it is written. But let me extend this point to other countries also. It is quite common in other race also. Pregnancy. The gallstone formation is very common in pregnancy. If someone is taking oral contraceptive pill, okay, because it contains estrogen there, Western diet, okay, Western diet, a bit of fatty type of diet, inflammatory bowel disease, especially Crohn's disease, because Crohn's disease affects terminal part of the ileum, so that one cycle known as enterohepatic cycle or circulation of the bile is impaired there. Hyperlipidemia, ileal resection due to loss of enterohepatic circulation, and then total parenteral nutrition, TPN. This total parenteral nutrition is when somebody cannot eat, okay, through the mouth for a long period of time, and the person is very sick. We give certain very dense type of nutrition to them, okay? Certain fatty acid, certain amino acid, and glucose, along with vitamins. Okay, so there are multiple mechanisms involved where the TPN can cause a cholelithiasis. Let's move on. So what you have learned, it is very common in female, and those female are relatively overweight or obese. Okay, they are in a reproductive age group, and these are the main problem here. Now, how to diagnose? What are the signs and symptoms of cholelithiasis? Let's talk about it. Most of those patients are asymptomatic. Now, in the beginning, they themselves don't know that they are having gallstone. Okay, a bit of dyspeptic symptoms can be seen. What is dyspepsia? Anyone? What do you mean by dyspepsia?
Sir,
Improper
there is a
digestion.
disturbance in the release of the hydrochloric acid.
Dyspepsia is improper digestion.
Okay. Now see that's quite a vague term. So whatever answers you are giving can be included in that meaning. Dyspepsia is a type of indigestion. It includes, gastritis, a bit of over secretion of hydrochloric acid, a bit of gas formation there, a bit of uncomfortable situation inside the abdomen. So all these are included under dyspepsia. So cholelithiasis also causes similar type of problem in the beginning. So it is not a bad idea just to go for the doctor and do one ultrasonography or ultrasound of the abdomen, because that can easily pick whether the person has gallstone or not. Not in the beginning though, probably after certain duration. Now symptomatic patient classically complain of severe right upper quadrant pain, because gallbladder is present there. Right upper quadrant pain, or you can also call it right hypochondriac pain, that radiates to the back, epigastric area, or even to the left upper quadrant, but that is a bit rare. It tends to be worse after eating, especially after fatty food, and may be associated with nausea and vomiting. Now, every student, I'm sure, know the correlation already. Why the pain of gallbladder stone is worse after eating fatty food? Why is that?
Sir, due to there is no release of the
Because there is no digestion of
bile salts and
fats.
non-digestion, and that's
Sir,
why,
because
sir, there
no
is
bile-
increased release of.
Sir, due to no bile, there will be no digestion, sir, which the pain will be severe after eating, sir.
Now,
Sir,
only,
after eating,
yeah, sure. Please go on.
yes, sir, after eating a fatty food, sir, cholecystokinin will release and will contract the bile, the gallbladder. That's why the pain will be severe that time.
Excellent answer. Very good. Now, see that just now what I told you, when we eat, especially the fatty food, okay, the cholecystokinin will be released. This cholecystokinin will contract the gallbladder. Now, in a normal person, nothing will happen. There's no pain because there's no stone inside the gallbladder, or there's no inflammation going on. But what is the difference here? There is stone formation inside the gallbladder, means already there is certain amount of inflammation going on. There's stone inside it. So when that gallbladder contracts, there will be pain. Okay, so it's all about relation of food, and that mechanism is induced by cholecystokinin induced contraction of the gallbladder. And that's why many of them, if the flow of the bile is not proper, then they cannot even digest the fatty food. Okay, they cannot digest the fatty food also. That is very true after cholecystectomy also. The symptom complex is called biliary colic and typically resolves over a few hours. Now this biliary colic, okay, it's a colicky type of pain. It's on and off type of pain. It is not a continuous type. Probably the pain lasts there for a few minutes, sometimes a bit more than that, and after some time, patient will be all right. And again, when the next episode of pain comes, patient will show that severe pain symptom once again. Let's move on. Now, a bit of facts about the cholelithiasis. Only 15% of the gallstone have enough calcium to be radio opaque. The majority of the kidney stone, however, have sufficient calcium to be radio opaque on plain flame. So to make it easy for you, what we say, almost 90% of the kidney stone are radio opaque, and almost only 10% of the gallstones are radio opaque. Okay, or you can say other way, 90% of the gallstones cannot be seen on X-ray, whereas 90% of the kidney stone are visible on the X-ray. It is all about how much calcium is there. Another one, there is a small, condition known as Meiji syndrome. This Meiji syndrome is external compression of the common hepatic duct by a gallstone, which is impacted in the cystic duct. Okay, see this? External compression of the common hepatic duct by a gallstone, which is impacted in the cystic duct. Till now, the common bile duct, we have not reached there. Common hepatic duct fuses with cystic duct, then only the common bile duct will be formed. But if there is a lodging of a gallstone in the neck of the gallbladder, which is compressed in the common hepatic duct, it almost acts like obstructive jaundice once again. So this is called Meiji syndrome. Now, these are the risk factors of cholelithiasis. We have already done this. Just a repetition for you. Female sex, they are fat or overweight or obese. The fertile belongs to the reproductive age group, 15 to 45 years. Okay, see this. Among that also, relatively upward, like the fourth decade, 40 years is most commonly affected. They are flatulent. They form a lot of gas inside the abdomen, and it may run in the family also, especially if they are associated with hereditary spherocytosis or hemolytic anemia. Now, how to make a diagnosis? It's very easy. Diagnosis is easier. Sometimes from the clinical feature alone, we cannot, clinch the diagnosis because many of the patients are asymptomatic. But if you strongly believe it may be a case of gallstone, just go for ultrasound. Okay, just go for ultrasound. So this is the procedure of choice. This is very easy to do. Okay, not very expensive test, and it can easily pick the gallstone. The classical findings in case of cholelithiasis in ultrasound are an acoustic shadow, that is like a headlight appearance, and there is a gravity dependent movement of the gallstone when we reposition the patient. So that shadow shift when we move the patient a bit. So this is classically seen, when doing the ultrasound or when we see those pictures. See here? Now, see this. Look at this shadow here. This is a stone and this is the shadow of that stone. This is highly typical of cholelithiasis. This is called a headlight appearance. Now, can you see, what are these images? Now look here. What are these? See this? Anybody? These are the gallstones, which are seen in the X-ray. These are seen on the X-ray. This is X-ray, plain X-ray of the abdomen. Now see this. These are the vertebra. These are the transverse process of the vertebra. You can clearly see. See here, some stones are here also. See, these all are the stone. This is a very rare case. Remember, only 10 to 15% of the gallstones are visible on the X-ray, and so much gallstone inside the gallbladder. So you can take or go for X-ray, plain X-ray of the abdomen also, but don't completely rely on it. Even if there are no stone visible on the X-ray, it doesn't exclude the diagnosis. You have to go for ultrasonography of the abdomen. So this is the plain X-ray, another film which is showing a bit of, see this radio opaque shadow on this area. This is right hypochondrium, exactly the area of gallbladder here. Okay, so you can see some radio opaque shadow here. Probably this is the case of gallstone. Now we'll confirm it by ultrasound. Now, what is the treatment then? Okay, what is the treatment of cholelithiasis? Asymptomatic cholelithiasis doesn't require cholecystectomy unless the patient is having these features. Now, see there. So asymptomatic cholelithiasis doesn't require cholecystectomy unless the patient is having these features. The first of them is they have a porcelain gallbladder. Now the term called porcelain gallbladder means when the wall of the gallbladder is extremely thick or fibrous, because that is an increase, there is increased incidence of gallbladder carcinoma if we ignore that. Porcelain gallbladder the lumen is very narrow and the walls are quite thick. If they have sickle cell anemia, we can go for cholecystectomy. Now, just now I told you, sickle cell anemia or other hemolytic anemia have a high chance of recurrent gallstone formation. That's why cholecystectomy can be done in this situation. One small question to you. What happens to the spleen in case of sickle cell anemia? Anyone?
Infarction, there is a vascular occlusive state. That's why, sir, there is a multiple infarction in spleen.
Good.
Splenomegaly.
Good. Good. Now see that in the beginning, you're right. In the beginning, there may be splenomegaly. Just in the beginning, though, okay, when the disease has just started. But the best answer in this case is autosplenectomy. Okay, autosplenectomy or splenic infarction, because sickle cell anemia is that type of condition where RBC will stick with each other, so there will be not a good amount of blood flow in multiple organs. Spleen is one of them, so different areas of the spleen are infarcted, so spleen will shrink in size and it looks like spleen doesn't exist in that patient. Now, this is not in connection with cholelithiasis, okay, but this is the way we have to study, because that is a very, very important question. Whenever your teacher hears the term sickle cell anemia, probably that question is asked to you. Now let's move on. If a stone is more than 2 to 3 centimeter, okay, there is a bit of chance of complication, so better to go for cholecystectomy. If it is a pediatric patient, okay, we have diagnosed quite early, so maybe associated with sickle cell anemia or other type of hemolytic anemia again, so better to remove it. And if the person is immunocompromised, there is high chance of inflammation, and that inflammation may spread, so better to go for the removal. Otherwise, we can wait. Now, the treatment is cholecystectomy. Cholecystectomy is the removal of gallbladder. We all know it. Cholecystectomy, excision or removal of the gallbladder. Now, this cholecystectomy can be done by two ways. One is called laparoscopic cholecystectomy, okay, and another is conventional cholecystectomy. See this, laparoscopic and conventional. If this is a pure case of cholelithiasis or gallbladder stone only, can safely go for laparoscopic cholecystectomy these days. And almost 95% of the patient, we can go for this. Okay, so please mute yourself. Okay, now what is the medical treatment after this? Now, is medical treatment available for cholelithiasis or not? Now the answer is it is available, but it is not that highly reliable. Okay, it is available, but not highly reliable. Nevertheless, we can start this type of drug called chenodeoxycholic acid or orthodeoxycholic acid. They'll slowly, make the gallstones smaller, and over a period of time, they may dissolve also. But it takes a long time and it's not reliable. So, if there is a proper indication, you straight away go for cholecystectomy. It's a safe type of surgery, not very expensive, and it will completely, treat the pathological process. There is a small condition known as hydrops of the gallbladder. Now, hydrops means a lot of fluid collection, and that fluid is mucus. Okay, that fluid is mucus. Why mucus is collected there? In the place of bile. Okay, so look at the mechanism. Sometimes there is a complete obstruction of the cystic duct by a gallstone, causing the gallbladder to fill with the fluid from the gallbladder mucosa, and the fluid looks often milky white. The color of the bile is green, but this type of fluid looks milky white. Now you may be wondering, where is the bile there? If cystic duct is completely blocked, bile cannot enter into the gallbladder at all, isn't it? So in the place of that, there is collection of the mucus. This is known as hydrops of the gallbladder. It clearly suggests a cystic duct is blocked by the stone. Now, with this, let's move on to the another part of the same spectrum of the diseases, that is acute cholecystitis. Acute cholecystitis. Now, what is the meaning? See here, inflammation of the gallbladder wall, usually due to obstruction of the cystic duct by gallstone, is known as acute cholecystitis. So this is acute inflammation of the gallbladder wall. You can also say that. And the common cause for this is a cystic duct obstruction by the gallstone. Now, what are the signs and symptoms? In acute cholecystitis, there is right upper quadrant tenderness and guarding. These are important features. Patient complains of pain in the beginning. When we examine, we can elicit the tenderness there. And there is usually guarding of the muscle. It usually lasts for more than 3 hours. Okay, sometimes maybe lesser than that also. This is also known as a colicky type of pain, because gallbladder, okay, is distensible sac. Remember, any distensible sac, any tubes, okay, or any hollow organ, if they are involved by any pathological process, then there will be colicky type of pain. But that colicky pain may be converted into continuous type of pain when parietal peritoneum is involved. The fundus of the gallbladder is covered by parietal peritoneum. So if that is involved, then that colicky type of pain will be converted into the continuous pain. A bit like, acute appendicitis, a similar type of situation. Now see here, patient may complain of fever, nausea and vomiting, very common, and anorexia. These are quite non-specific features because they may present in so many other conditions also. But if fever, nausea, vomiting, and anorexia are present along with right upper quadrant tenderness and guarding, then we can clearly think about acute cholecystitis. Now, Murphy's sign is a very important, clinical findings in case of acute cholecystitis. Now, listen properly how to elicit Murphy's sign. We ask the patient to lie comfortably on the bed. That's the first thing. Second, okay, we palpate for the fundus of the gallbladder, which is present near the tip of 9th costal cartilage on the right side. Tip of 9th costal cartilage on the right side. So what we do then? Ask the patient to take deep inspiration, okay, or deep breathing. Now, this patient is having inflammation of gallbladder. You can clearly see that. So when a patient is taking deep inspiration, the gallbladder along with the liver will move downward. What are you doing? You are palpating the gallbladder with your finger, means you are pressing there with your finger. So the descending gallbladder, because of deep inspiration, will touch the finger which you are pressing there, and that can lead to severe pain in the patient. Okay, that can lead to severe pain in the patient. This is known as Murphy's sign. Because of severe pain, the patient catches their breath. See this? Inspiratory arrest means they catches the breath. This is positive in about 1/3 of the patient only, may not be present in all. It depends of the inflammation there. So Murphy's sign is an important question which will be asked in your MCQ exam. Remember, it is connected with acute cholecystitis. Another way of eliciting this is sonographic Murphy's with the help of ultrasound probe. Okay, when the doctor is doing ultrasonography there, they can press exactly at that gallbladder area with ultrasound probe and ask the patient to take deep breathing. Our patient is doing that actually. So patient shows, wincing feature on the face, means they are having pain. So it has a very good amount of sensitivity, almost 87% sensitive. So this is a good test to do during ultrasonographic examination. 1/3 of the patient develop exquisitely tender right upper quadrant mass late in the course. Sometimes there is a mass formation also when parietal peritoneum is involved, the structure which are there may go and attach at that area. So it forms a mass. Now let's move on. So in acute cholecystitis, okay, the pain is similar in character to cholelithiasis, but typically lasts longer because of the involvement of a peritoneum or fundus of the gallbladder. So it is a longer duration pain. In the beginning, it may look same. I already explained the mechanism. Now, how to make a diagnosis? Very easy question again. The diagnosis is done by ultrasound. Ultrasound is the most important test once again here. Okay, but there are certain other tests we can do or certain other investigation, and these are the lab. A lab investigation like CBC. CBC shows leukocytosis. Okay, leukocytosis, because this is a case of infection. Infection leads to leukocytosis, with or without increased alkaline phosphatase. Now, let me ask this question to you. Why alkaline phosphatase is high in this case? Anyone? Anybody?
So because biliary duct and in the area contain the these enzyme, that's why sir it increase.
Very good answer. Yes, that's the answer we want. We want to hear. Alkaline phosphatase is an enzyme which is connected or associated with biliary duct or biliary system. This is a part of the biliary system, and it is usually associated with gallstone. That means some amount of obstruction is always there. So alkaline phosphatase, if it is high, don't be surprised. You have got a correlation there. But if there is no amount of obstruction of the biliary channel or duct, then alkaline phosphatase may still be normal. Other LFTs also should be done to rule out the differential diagnosis. LFT, remember, what is the total bilirubin? What is the direct component? What is serum albumin level? What is prothrombin time? Okay, what are the liver enzyme? These are called LFT. Amylase and lipase. Now, these are important tests to rule out pancreatitis, because these are the differential diagnosis: acute pancreatitis, acute cholecystitis. To rule out acute pancreatitis, you go for amylase and lipase test. And total bilirubin we already talked about. Okay, this is urine analysis, chest X-ray, and abdominal X-ray also can be done. Urine analysis, okay, chest X-ray and abdominal X-ray. This urine analysis can be done because patient is having fever, or patient is having some abdominal pain, and urine analysis is a routine test we do in those type of situations, especially in case of female. Chest X-ray can be done, and abdominal X-ray also can be done. Now, what about the ultrasound? What ultrasound will reveal us? Ultrasound shows inflammation of the gallbladder wall, which is more than 3 millimeters, because there is inflammation. Inflammation means swelling of the gallbladder wall. In chronic cholecystitis, it's even thicker than this. There is a collection of pericholecystic fluid, again as a result of inflammation, and already talked about, it is strongly associated with cholelithiasis. So there is usually stone in the gallbladder. So all of these things together will clinch the diagnosis. The positive predictive value of all these three is more than 90%. Okay. Now, what is the risk here? Okay, think about it. If the stone which is there in the gallbladder somehow enters into the cystic duct, and if it passes distal to the cystic duct, where it will enter? Where it will go now?
Common bile duct.
Common bile duct.
Common bile duct.
It can also cause.
Exactly. It will usually go to the common bile duct. Okay, because common bile duct is formed by the union of cystic duct and common hepatic duct. And I'm telling the stone is a relatively smaller one. So it will go to the common bile duct. Now, common bile duct is obstructed or blocked. that can also be picked by the ultrasonographic examination. And remember, whenever a duct is obstructed or blocked, okay, the part of the duct which is proximal to the obstruction or blockage is always dilated. It is dilated, and the part of the duct which is distal to the obstruction looks or seems to be collapsed. Means the diameter is small there, whereas the diameter in the proximal part is bigger one. So this is a very important point to remember. Yes, there is some amount of obstruction present. Now, another important test which is asked in the exam, or in the MCQ exam actually, is the HIDA scan. Okay, HIDA scan. This HIDA is radioisotope material. So let me explain the principle here first. Okay, why we go for this test, why it is written most sensitive here. Now see this, in case of inflammation of the gallbladder, there is non-filling of the gallbladder even when the small bowel is visualized, is characteristic point of acute cholecystitis. Now it is very easily explained with the help of these pictures. Now all of you, please focus here. Just see there, please. What is shown here? Okay, see this. This is a normal HIDA scan. Okay, and this is the HIDA scan consistent with acute cholecystitis. This is acute cholecystitis. Now see this. What is the difference? In a normal person, we can clearly see the whole anatomy of the biliary channel. It is nicely excreted there. Okay, then the biliary duct is also seen here. The biliary duct is also seen, and this is the image of the gallbladder. You can clearly see it because this person is normal. There is no inflammation going on. But see this here. I cannot see the feature like this. The shape like a gallbladder is not seen here. Only the liver shape is seen. This is liver. Okay. Where is the gallbladder here? I cannot see. So if this is seen after HIDA scan, or which is a radioisotope material, then the diagnosis is very easily confirmed. HIDA is a type of chemical material which is known as hepatobiliary immunodiacetic acid, but that full form is never asked to you. If you say HIDA scan, we believe why this test is done. Now a little bit of summary. If your teacher asks what is the most important test, or what is the most routine or common test you still want to do to confirm the diagnosis of acute cholecystitis, your answer is ultrasound. But HIDA scan is the most sensitive one, okay, among others. We're talking about the different type of investigation we need to do for the confirmation of acute cholecystitis. So I told you the most commonly done test is still ultrasonography. This is a very sensitive type of test and quite easy for the patient and for the doctors to do as well. But if the question is what is the most sensitive test among all, and if there is option called HIDA scan, you go for that because that's highly sensitive for the detection of cholecystitis. Now this is how the ultrasound examination looks like. This is a normal gallbladder. Okay, normal gallbladder. See this? This G is the letter we written here for gallbladder. And this is a cystic duct. Now see this, how it looks in cholecystitis. See this. Okay, this type of appearance is seen in acute cholecystitis in right upper quadrant ultrasound. So relatively thickened gallbladder wall. Okay, this is another picture. It is showing the same thing. This is gallbladder, and there is a thickened wall of acute cholecystitis. Now, After the confirmation of a diagnosis, let's talk
Excuse me,
about
sir.
how to manage. Yes, yes, yes.
Sir, in the previous slides, sir, in lab investigation of acute cholecystitis, sir, in increased lipoprotein lipase, ALP and LFT, sir, which one is the most specific lab investigation?
You mean lipase, amylase, and ALP? Your question is
And
that?
sir, sir, and between the LFT, sir, in LFT, sir, there are a lot of things like bilirubin
Okay,
liver enzymes.
I got your question. So
Therapy.
yes, because this is a common type of investigation which is done as a result of the place where we believe that area is affected, that is liver site. But LFT may not be that affected in a pure case of cholecystitis because it may not have any connection with derangement of the liver function. If there is no obstruction of the biliary duct, okay, or if there is no inflammation of the biliary duct, then there probably may not be any change in liver function test. They can still be normal. But if it is altered as a result of biliary stasis or biliary infection or inflammation, what will be the result. Bilirubin may be high, a bit of direct component may be there, and alkaline phosphatase is the enzyme which is elevated rather than other two, okay, like ALT and AST. They are usually normal in this type of case. So we cannot pinpoint which test is more sensitive or specific here because most commonly they are not affected at all. They are not affected. Only some complicated situation they may be affected, like biliary stasis or biliary inflammation. Now,
Okay, sir.
let's no problem. Let's talk about the treatment part. So this is a bit of different situation than only gallstone. You all know that this is an infection going on there. Okay, probably role of microorganism there. So treatment is a bit of challenging. See this? Please mute yourself. I can get some disturbance from the student. Wait. Okay, now it's fine. So the first thing we do is nil per oral, NPO. Now you all know why NPO is done here, because we want to give rest to the gallbladder. We don't want that inflamed gallbladder to contract. Okay, so nil per oral is usually advised for the patient for few days. IV fluids started whenever we put nil per oral, because patient has to get some fluid into the body. So IV fluids are routinely given. This is an infection case, so IV antibiotics are of course started. This is a broad spectrum IV antibiotic, and IV analgesia because there is pain in the patient. Okay, usually morphine can be given or pethidine can be given. Cholecystectomy is done within 24 to 48 hours after the hospital admission. After we do all these things, after we make the patient ready, then go for cholecystectomy. Cholecystectomy is the removal of the gallbladder, you all know. Now, this cholecystectomy can be done by two ways once again. Most commonly done is laparoscopic way these days. Now, there is a huge advantage of laparoscopic cholecystectomy over the conventional cholecystectomy. Laparoscopic cholecystectomy has a very small scar. Okay, few openings are made on the intra-abdominal wall, and with the help of a special instrument called laparoscope, the gallbladder is removed. There is very minimal days of hospital stay, and patient can come back to the work much earlier. Whereas conventional cholecystectomy has a large scar there. A lot of tissues are cut. This is a conventional type of surgery. So that's why laparoscopic is replacing the conventional surgery these days regarding cholecystectomy. Having said that, if you think there is extensive type of adhesion, okay, a bit of complicated situation, then laparoscopic cholecystectomy will be converted to open cholecystectomy or conventional cholecystectomy. It depends on the surgeon what they think. Let's move on. Now, on the admission, we start IV fluid, already talked about, and broad spectrum antibiotics. The patient should be placed on NPO, and monitored for 48 hours. NPO means nil per oral. We don't give anything for 48 hours. Patient, it doesn't happen anything to the patient because we have already started IV fluid. So you don't need to worry about the nutrition for at least 48 hours. But longer, duration of NPO is not advisable. Okay, after that, if symptom resolve, patient can get elective cholecystectomy within 6 weeks. If symptom continue or worsen, patient should get urgent cholecystectomy. Now see that. So what is the meaning there? If only this conservative treatment, okay, make the patient better, there's no pain, there's no fever, patient looks all right, that you don't need to go for a cholecystectomy right now. You can postpone cholecystectomy after 6 weeks. This is known as elective cholecystectomy now. But if symptoms continue or even worsen after we start this conservative therapy, patient should get urgent cholecystectomy. Having said that, many of the surgeons, they don't go for elective cholecystectomy. They go for urgent cholecystectomy. There are multiple reasons for this. Number one reason is patient is right there now in the hospital. Okay, so if you postpone it, you have to discharge the patient, and they have to gather that momentum and come back for the surgery again. They should be motivated again. So sometimes they may not come back at all. So why not to take this opportunity or chance when the patient is still there in the hospital? So that's what many of the surgeons think. And patient party also thinks that if it has to be done, why not now? Okay, so usually, although this is a theoretical type of discussion, we can postpone it, but usually it is done right then. Now, let's move on. There is a term called as emphysematous cholecystitis. What is this? Sometimes a small question can be asked. This is a severe variant of cholecystitis, which is caused by gas-forming bacteria. Okay, caused by gas-forming bacteria. Can you tell me one of the example of gas-forming bacteria quickly? Yes.
Clostridium perfringens, streptococci.
Very good.
Clostridium is the most common ones.
Very good. Very good. Excellent answer. Clostridium perfringens and some other bacteria like streptococci, peptostreptococci, and those type of bacteria. Okay, so these are the gas-forming organism. This is a relatively rare type of condition, but often results in perforation of the gallbladder, which is having high mortality and morbidity. Now, a bit of perforation of the gallbladder, though later we'll again discuss this. If gallbladder is perforated, whatever content this gallbladder is having, that is bile, we all know, concentrated bile, will leak into the peritoneal cavity. This leads to biliary type of peritonitis. This is a chemical peritonitis. In the beginning, it is chemical, but later on, this chemical peritonitis will be taken over by bacterial peritonitis. Very serious situation. Patient usually die if that thing happens. One more thing, whenever the gallbladder is perforated, remember the gas, okay, the gas may be seen in the biliary channel or the duct, and we can detect that with the help of X-ray. So this is a way of diagnosing the case. It typically affects elderly diabetic men because they are immunocompromised. We cannot even detect whether they are having fever or not because they don't develop fever usually. So how to know where there is inflammation, whether inflammation or not? That's why the detection is late, and late type of detection can have a lot of complication like this. So this is abdominal X-ray. Okay, this is the short form for abdominal X-ray, demonstrating rim-like gas within the gallbladder. See, this is the gallbladder area. Okay, we can have some gas collection here. This shown by these arrows. Other gases are caused by so many other structure inside the abdomen. You all know that. Okay, so well, this is a funding gas shadow, and all others are formed by the intestine. Now, this is a CT scan which shows this is the area of a gallbladder. Okay, here in the lumen and inside the wall of the gallbladder. Look this bright, black appearance. Now, let's move on. Another type of cholecystitis is called acalculous cholecystitis. Acalculous means there is no stone in the gallbladder now, but it is inflamed. So regarding the definition, this is acute cholecystitis without the evidence of gallstone, and it is thought to be due to biliary stasis. Biliary stasis means bile is not flowing, bile is not going out of the gallbladder. So bile stays there, and then there is migration of bacteria leading to acalculous cholecystitis. There is no stone there. Regarding the incidence, 10% of cases of acute cholecystitis are acalculous 1. Okay, and it is usually associated with some serious illness in the patient, some type of debilitating disease in the patient. We'll talk about it. Look at the risk factor here, then you yourself realize. See this? Most often, this type of acalculous cholecystitis is seen in intensive care unit patient. That's why I say sick and debilitated patient with multi-organ system failure.
Sir?
Yes?
Sir, in the last slide, sir, sorry to interrupt, but sir, in the last slide, sir, you said about this acalculous cholecystitis, sir, due to the presence of bacteria. But sir, can it also be due to the sir, due to stasis of the bile, the biliary enzyme get activated, sir, which can lead to damage of gallbladder, can also lead to cholecystitis.
Yes, in the beginning, you're right. This is the chemical type of inflammation, chemical. Bile can give rise to irritation there. It's a chemical type of inflammation. But
yes, sir,
usually even normal or healthy gallbladder is also having bile. Then another question comes, why that healthy gallbladder is not attacked by the bile then? Okay, so something is going on there. First of all, there is a stasis of the bile because of multiple factors. Probably the contraction doesn't happen, the stimulation doesn't come there, patient is seriously ill. Okay, there may be migration of the bacteria from the GI tract towards the biliary tree. So all these factors are responsible here. So it is not because of only one factor. Now see here. So multiple organ system failure, trauma. This is multiple trauma. Okay, like a massive road traffic accident, okay, or fall from a height, or even after major surgery, after burns, 3rd-degree burn, major type of burn, sepsis or septicemia, and total parenteral nutrition. Now, usually, the common link between these risk factors is patient is seriously ill or sick, and during that time, the patient is immunocompromised as well. And after that, there is migration of the bacteria from the GI tract, which are normal commensal, into the system, and they can cause cholecystitis as one of the affection. Regarding the diagnosis, okay, we should take help of the lab, like leukocytosis is there, with or without alkaline phosphatase enzyme, already discussed, and not always it is raised. We have to go for LFT also, amylase, or even lipase, and total bilirubin level. Now, one small difference between the calculous cholecystitis and acalculous cholecystitis is liver is usually affected in this case because the person is very sick. The same type of illness, which is affecting cholecystitis may be causing affection of the liver as well. Another one is ultrasound. Ultrasound will show or confirm your diagnosis. It will show biliary sludge and inflammation. Biliary sludge means the bile is concentrated there. Okay, it is not flowing there properly. Sometimes there may be already complication developed in case of acalculous cholecystitis, like gangrene of the gallbladder, empyema of the gallbladder, or even perforation of the gallbladder, which can be easily picked by ultrasound. And I already told you these patients are relatively immunocompromised. They are debilitated, very sick patient. So signs of inflammation cannot be shown properly by them. So by the chance we diagnose it, already there are high chance of complication. HIDA scan also can be done here as well. Now, a bit of a similar thing, except there is no stone here. This is gallbladder wall thickening. Okay. See this between the two arrows, this is wall of the gallbladder, and there is a bile. So this is how acute cholecystitis looks. This is another picture. Okay. Now, let's talk about the treatment. What should we do? Urgent cholecystectomy is the treatment for acalculous cholecystitis. Percutaneous cholecystostomy is an option in patient with high surgical risk. What does that mean? If the person is so debilitated, the condition of the patient, the vital signs are unstable, I cannot go for surgery of that case. Patient may die, okay, under the table. So in that situation, better to go for cholecystostomy. What do you mean by that? Anyone? What is this? See here, just analyze it. Percutaneous cholecystostomy. This is not cystectomy.
Respiration.
There is a sir, there is a formation of a stoma in the gallbladder. Sir, there is a placement of a tube. Sir, where is there? Sir, then there is a placement of a tube for drainage, sir.
Both of you are correct. Both of you are absolutely correct. This is the drainage of the gallbladder. Okay, it's an aspiration type of thing. But we do not only aspirate it. He's right. We probably convert this into a stoma. Then whatever the infected, bile is there, it will be drained outside. So this is a percutaneous cholecystostomy. This is the option here because we cannot take the patient for surgery. Patient may die. Patient is unstable, okay, with unstable vital sign. So this is one of the options. Now, cholecystectomy is routinely indicated in this type of situation. This is surgical removal of the gallbladder. We all know it may be done via the open or the laparoscopic way. Okay, open is done by the Cocker's incision, which is known as right subcostal incision. The special term is Cocker's incision. Or if you cannot remember this, you can simply say right subcostal incision is given for the cholecystectomy surgery. Now, laparoscopic is done by 4-port technique. You don't need to know detail regarding this. Okay, surgeon is going to do that. If you later on choose surgery as your a postgraduate subject, then you can go for the training and all those things here. The safe dissection is done through the Callot's triangle, and if the whole gallbladder cannot be safely removed, then partial cholecystectomy should be done. Now, okay, let's move on. These all are related type of topics, but very small one. And I'm sure when we discussed a long time ago in pathology, we already talked about this there. So a bit of good correlation. What is choledocholithiasis? What is that? Why? For what we use this term? Yes.
Sir, it is a
Stone in the common bile duct.
Sir, in the common bile duct, sir.
Exactly. It is a stone in the common bile duct. Choledocholithiasis. Remember, this doco is the term you use for the bile duct. The stones in the common bile duct, and this can but does not necessarily cause cholecystitis. It may be associated with cholecystitis, but not always. Sometimes what happens, a simple stone, a small type of stone may dislodge first into the cystic duct, and from there it enters into the common bile duct. Now this stone may cause obstruction there, okay, or it depends how distally it reaches. Most commonly, only obstructive jaundice is caused by this, but sometimes even acute pancreatitis is caused by it if it reaches the ampulla mater and if it lodges there. Regarding the incidence, this is found in 6 to 15% of acute calculous cholecystitis and 1 to 2% of acalculous cholecystitis at the time of surgery. Okay. But you may argue acalculous cholecystitis, isn't it, doesn't have any connection with the stone. But sometimes what happens? Inside the gallbladder, there may not be any stone, but already the stone may be slipped out of the gallbladder also. Regarding the signs and symptom, epigastric or a right upper quadrant pain and tenderness may be there. Now, let me tell a bit more about this, a bit more clinical knowledge. The pain in choledocholithiasis is very, very severe pain. Now, what type of pain will it be? Can you tell me what type of pain here?
Colicky
Colicky?
Colicky pain, sir.
Colicky type of pain.
Sir, it's a tubal structure, that's why it's a colicky pain.
Exactly.
Maybe, sir, it does not involve the parietal peritoneum up to now.
Exactly. Exactly. All of you are correct. Very good answer also, with reason, because this is a tube. Okay, it doesn't involve peritoneum. So this is a pure type of colicky pain. And it is one of the most severe pain the patient feel. The patient cry during that time. Trust me, I have seen few cases. Okay, the patient was my mother herself, and during that time, okay, we diagnosed it later. She virtually cried with pain whenever she had, this type of choledocholithiasis pain. It lasts for a few minutes, and they really struggle to bear that pain during that time. Now, tenderness may be seen during that time. If you feel or palpate that area, tenderness may be there. After a few minutes, the pain will disappear, and it looks like they're fine now, but they're so afraid that pain may come back. Jaundice is a routine feature, and you know why jaundice is there. It is an obstructive type of jaundice. It is also known as cholestatic jaundice. And in the beginning, probably the jaundice is not that very severe, but it depends how bad is the obstruction, how complete is the block. If it is completely blocked, the jaundice is severe one. After obstructive jaundice, it may be complicated by cholangitis. Now, there is the inflammation or infection of the common bile duct. This is a serious disease. We'll talk about it later, okay, or probably in the next class, okay. But inside this topic itself, cholangitis is the infection of the biliary duct. There is high-grade fever now, usually with chills and rigor. The jaundice will further increase, and within a short period of time, if we do not detect this, patient develops sepsis. There may be recurrent attacks of acute pancreatitis without other non-risk factor, because one of the most common cause of acute pancreatitis is gallstone. And in this case, okay, the gallstone has entered into the common bile duct, and I already told you so many times, if this is small, stone is a relatively small one, it may lodge right there in the major duodenal papilla or ampulla of Vater. Now, what will happen? Whatever secretion is coming from the pancreatic duct into the second part of the duodenum cannot occur. There is increase in back pressure that will cause acute pancreatitis. Let's move on. Now, how to make a diagnosis of choledocholithiasis? So these all, condition, whatever we have discussed till now today, the diagnostic features are a bit similar. So we can go for the lab investigation like LFT. Okay, you can go for CBC, and you can also go for some liver enzymes. You can also go for amylase and lipase, the same type of test whatever we discuss. But having said that, in this condition now, what will happen? There is increased alkaline phosphatase, usually 100% of the time. Now, every student know the reason here, because it is associated with obstructive jaundice. Biliary duct are affected here. That's why alkaline phosphatase is high. LFT may be dearranged. Now, may be dearranged. How to explain this? Okay, please listen properly, then you'll never forget. So what will happen in the beginning? Only alkaline phosphatase enzyme is high, but it depends on how bad is the obstruction. If obstruction is completely blocking the flow of the bile, what will happen? There is back pressure development. The bile will be collected inside those biliary canaliculi inside the liver. Now, after they damage the biliary canaliculi, now the damage is reflected back towards the hepatocyte cell membrane. Now, if hepatocytes are damaged, then even AST and ALT can become high. But it takes time. It depends on how bad is the obstruction. Having said that, the level of ALP is many more fold higher than the level of AST and ALT rise in this case. So this is how you always make a diagnosis. Never make it as 100%. Oh, this happens only in this case, but that happens only in that case. It all depends on the relative factors there. Which one is more affected than the other? The concept is important, and the reason what you give is important in this type of case. Now, total and direct bilirubin is high. Why they are high? Because of obstructive jaundice. Total bilirubin, of course, is high, and direct component is high because in obstructive jaundice, that is the one, okay, which is elevated. So another important test, what we can do is ERCP. Okay. What is the full form of ERCP?
So it is endoscopic retrograde cholangiopancreatography.
Excellent. Okay, I'm sure many other students know that also because we have been talking about this from the last few classes. Endoscopic retrograde cholangiopancreatography. Now, with the help of endoscope, we do this test, or procedure you can say. We put endoscope, insert the endoscope reaches the second part of the duodenum, isn't it? And from there, okay, we go upward. That's why it is known as reverse endoscopic, retrograde reverse cholangiopancreatography. This is a gold standard for the diagnosis of CBD stone, and it also provides a therapeutic option there. If a stone is a small one, if it is exactly at the ampulla vater or distal part of CBD, you can remove it while doing ERCP. So this is the therapeutic option. Another one, okay, see this is endoscopic ultrasound. This is less sensitive than ERCP, but also less invasive and more sensitive than the transabdominal ultrasound. But for this, you have to do endoscopy. So endoscopy is an invasive type of procedure. So that's why the popularity of this test is not that high. We still go for transabdominal ultrasound in this type of cases. Now, transabdominal ultrasound is highly specific, but not very sensitive for CBD stone. But nevertheless, a good radiologist will pick it up. And if all these tests are done, then we can do correlation. Now, let me give you one explanation, a situation here. You have done LFT. It shows increased ALP. Okay. It also shows high TSV and direct component. That is one part. Now you have done transabdominal ultrasound. It is suspicious that there is a CBD stone. You can also see a bit of dilated proximal part of the common bile duct. Now, what else you need? Okay, just correlate the things. Patient history is already there. The clinical examination points are already there. And this is how we reach to the diagnosis. So don't ignore your history and physical exam. Never. Combine some important point from the lab. Then synthesize the history. This is called synthesis of the diagnosis. So you have to synthesize the diagnosis after you get all important points. Now, this is a right upper quadrant ultrasound, which is showing a choledocholithiasis. So there is a, see this image like that, and this is a CBD or common bile duct, and here is a stone. Now, what is the treatment? Treatment can be done with the help of ERCP, endoscopic retrograde cholangiopancreatography, because it is not only diagnostic, it is therapeutic as well. So treatment can be done with the help of ERCP. So it involves endoscopic sphincterotomy with retrieval of the common bile duct stone with a basket, and this is 85 to 95% successful. So this is a wonderful type of therapy. Endoscopic sphincterotomy. Now we all know sphincterotomy means division, okay, division of the sphincter there. So this is the sphincter of OD we are talking about. If ERCP fails, the CBD can be opened surgically and the stones removed. This is a conventional surgery, and this is a big surgery. You have to give incision in the right upper quadrant. You have to reach to the common bile duct. Okay, make sure where is the stone, incise that part of the CBD, remove the stone, and then put a T tube. See this is called T tube, which is placed so bile can drain externally. We want to give a bit of healing time for that common bile duct because it is injured, it is damaged during surgery. That's why T tube is placed, okay, and it is removed after 2 to 3 weeks. This is followed by elective cholecystectomy. Elective cholecystectomy, or sometimes the surgeon can remove the gallbladder right then also. It depends. Already discussed. But some believe it's a big surgery. Already I have done enough damage of the CBD. So let's send the patient home and let them call back later on and do the elective cholecystectomy. I'm sure you know the meaning of elective surgery and emergency surgery, right? What is elective surgery, by the way? What type of surgeries are elective? Anyone? Elective means what?
So elective means
Elective
we give proper time for patient for the.
And sir, the emergency surgery, sir, when we do it, like sir, if there's any type of emergency and we have to treat it on the spot, so then we do an emergency surgery.
Absolutely correct. Both of them are right. Emergency means right now. We don't wait. If we wait, there may be some serious damage to the patient. There may be complication. So remove it. Remove that area. Remove the pathology. This is emergency. We don't wait any longer. Elective, we can wait. Okay, wait for the appropriate time. Give some date to the patient. Yes, come back after 1 week. I'm going to do it then. Come back after 1 month, 6 weeks. Okay, 6 months. So this is an elective surgery because no serious damage is expected in the patient soon. It's a very common term, in clinical medicine. Very common term. Okay, wait. Let's move on. Now, a small topic which is quite related with the things which we are talking right now is called cholangitis. Now, please pay attention. Cholangitis is acute ascending type of cholangitis and sclerosing cholangitis. That term sclerosing cholangitis is strongly associated with inflammatory bowel disease. We'll talk that later. But right now, let's focus on ascending type of cholangitis. This is a bacterial infection of the bile duct, usually associated with obstruction of the common bile duct by gallstone. So easy. Now, at this moment, because all these are related topics. So what will happen first? There is a stone inside the gallbladder. The stone is slipped out of the gallbladder neck, enters into the cystic duct, and through that into the common bile duct. The common bile duct is blocked by that stone, and then it is getting infected. Regarding the signs and symptoms, there is fever and chills. This is a high-grade fever with chills and rigor. Even rigor is there. Okay, so don't forget. This is one of the situations where fever with chills and rigor is seen. What are the other conditions where fever with chills and rigor occur? Yes.
The pyelonephritis.
Yes, sir.
Good. Any other? Excellent answer. Pyelonephritis. Remember malaria. Never forget malaria as a cause of fever with chills and rigor. Classical case malaria caused by Plasmodium species. Then abscesses in the body. Wherever the big collection, not the small one, okay, big collection of abscess, then usually the patient is having fever with chills and rigor. And sometimes it has been seen that even in lobar type of pneumonia, there is a fever with chills and rigor. Lobar pneumonia. Sometimes your teacher may ask question like that. Patient is having nausea or vomiting, non-specific feature again. They do not cleanse the diagnosis, and there is abdominal pain with or without altered mental status and the features of septic shock. This ascending cholangitis is a life-threatening emergency which is precipitated by any irritation or obstruction of the biliary tree, and usually that is done by stone blockage there. This altered mental status is all because of the infection which is spread in the body. Now, this is a true medical or surgical emergency. In the beginning, we go for the broad spectrum antibiotic therapy, okay, and later on we have to remove the obstruction. Okay, so let's move further. There are some important points regarding cholangitis and choledocholithiasis. One of that is called Charcot striate, very commonly asked in the exam. Charcot striate. It's a combination of right upper quadrant pain, fever, and jaundice. So of course this is seen in cholangitis, right? Because there's a fever. It's a part of infection. Right upper quadrant pain, usually a colicky type of pain, fever, and jaundice together is called Charcot striate. Now there is another important term known as Reynolds pentad. Reynolds pentad. So we add two more things on the Charcot striate. Charcot striate is there, plus central nervous system symptom like altered mental status and septic shock together is called Reynolds pentad. So it is also seen in acute cholangitis. Now there are some common causes of common bile duct obstruction. Common causes of common bile duct obstruction apart from the gallstone. These are known by a mnemonic called SINGE. Okay, S stands for stricture of the bile duct. Stricture means acute narrowing because of the scar formation there. Iatrogenic causes, ERCP or PTC. This is percutaneous cholangiogram or biliary stent placement. Neoplasm, gallstone, extrinsic compression from the pancreatic cancer, pancreatic pseudocyst, or pancreatitis. Okay, so these are some of the common causes of CBD obstruction. Not always it is caused by gallstone. Sometimes it is caused by other causes as well. Let's move on. Now, how to make a diagnosis or confirm the diagnosis of cholangitis? We go for the certain lab test because a case of infection. Lab usually show leukocytosis with increased bilirubin, ALP, and LFT. Now let me explain this once again. Okay, though many students know it already. Case of bacterial infection, so leukocytosis is quite common with neutrophilia and bilirubin because biliary obstructive jaundice is there. So total bilirubin is high along with direct component. Alkaline phosphatase is always high in this type of case. And if the blockage is severe enough, then other enzymes can also be high as a result of obstruction of the bile flow at the liver site. Ultrasound is a very important test. It should be the initial study. Dilation of the common and intrahepatic bile duct along with gallstone and a thickened edematous gallbladder wall can be seen. These are the part of acute cholangitis. Remember, acute cholangitis usually occur on the setting of choledocholithiasis. So these are the common features on ultrasound. ERCP, okay, is another important test, and percutaneous transhepatic cholangiography is the another one. Percutaneous transhepatic cholangiography, PTC, we say, the another one, also sometimes called as PTCA. It provides a definite diagnosis, can also be therapeutic, especially ERCP can be a therapeutic. There is a small stone which is causing all the problem at the distal end of a common bile duct. We can remove it. Bile culture should be done because this is a case of infection. So this culture can grow microorganisms which are responsible, that we can choose proper antibiotic. Okay. Now, what about the treatment? So let's complete the discussion by talking the treatment. Remember, this is a medical or surgical emergency, so we have to go for nil per oral, IV fluids, and IV antibiotics in the beginning. Nil per oral to give that biliary system some amount of time of rest. IV fluid and IV antibiotic are very important part of the management, especially IV antibiotic, because this is infection and this is a rapidly spreading infection. So broad spectrum antibiotics are commonly chosen. The patient is already in shock, especially septic shock. Decompress the bile duct and remove the obstruction immediately. You don't have time, septic shock in emergency situation. So all these things has to be done right there. It is done by ERCP or PTC. If unsuccessful, then intraoperative decompression with T-tube placement is indicated. This is a proper surgery. Okay, T-tube placement. For example, you have given incision on the common bile duct. Now the bile should be diverted. This is done by T-tube placement. And after a few weeks, T-tube is removed. If the patient is stable, continue conservative management with definite treatment later. So this stable means the vital signs are stable, patient doesn't look that sick. So we continue the conservative management with definitive treatment later. Definitive treatment means surgery later. Urgent biliary drainage is necessary for the patient, definitely, because there's a big amount of obstruction. So this is done by percutaneous transhepatic cholangiogram or via ERCP. We already talked about it. ERCP can also remove the stone. And elective cholecystectomy should follow later on. It depends. Okay, so this is all about the treatment of acute cholangitis. Okay, so let me stop here for today.